service. If a patient comes to my clinic with a reproductive health emergency, I'll be afraid to provide that particular service. And if you look at the Malindi case where one of the healthcare workers was actually arrested, and yet if I don't provide that service, the same constitution provides a provision for emergency services. So I'm caught in between a rock and a hard place in terms of what should I do in this case. But there's a deliberate move in terms of actually even raising the age of consent. Because at the end of the day, a patient comes to your clinic and is, example, 20 years old. A youth is 20 years old. You cannot provide service according to the current reproductive health service, which says that this adult should be accompanied by the guardian for her to actually be able to access that service. So what that does, in essence, it pushes, because you are not able to provide it as healthcare workers, then it pushes these young people to go and access the service from quacks. And this now presents even a bigger problem, because if you go just to Mama Lucy or Muhanga County Hospital, or even Thika Level 5, there's a Ward 6 there. And you can actually see how we are losing so many young women because of these restrictive laws and policies that are being made, not based on science, but have been made from a religious angle. And actually there's a move that I'm sure even when I was talking to Dr. Kangaude in Malawi and other East and Central African countries to have those kind of policies and laws in place. So what they are doing, they're preventing healthcare workers from actually doing what they were trained to do, which is provide health services. And by doing that, then they open up another port of where quackery now comes in, where we are losing a lot of many young girls. Every year, in 3 months' time, we'll have lost 3,000 young women to unsafe abortion. Our maternal mortality rate is rising up. It's now 441 deaths per 100,000 of the population. Why? Because more than 500,000 abortion-related complications contribute to this. And you cannot continuously bury your heads in the sand or allow such a restrictive environment to exist, is because then as medical providers, we are not able to have that autonomy to provide our service with professionalism that we've been trained to do. So that is the impact of this, allowing these laws and policies to be enacted, and actually contradicting the Constitution.
Thank you, Dr. Were. And you were, as you were speaking, I just thought about the statistics that you mentioned: 500,000, maternal morbidities and mortalities related to unsafe abortion. Just to go back to the issue of access to safe and legal abortion, Martin, you've had a chance to litigate before national courts, before regional courts on access to safe and legal abortion. We all know 13 years after the passage of the 2010 Constitution, Article 26(4) that provides access to safe and legal abortion continues to face constant attacks from different quarters. And again, the same statistics that Dr. Were is mentioning, women continue to die daily because of these, restrictive legal and policy framework. So what are some of the best practices, that we can learn from national courts, whether in Kenya, in Malawi, or in Nigeria, towards the full realization of SRHR rights for women and girls? Thank you.
Thanks, Prudence. One, I'm glad you came and sat here. Our panel was, the optics were looking bad. I wanted to explain that actually we also have a panel currently sitting in Arusha that is all female. So I'm the one who was dragged to come and join last. But thanks so much, Prudence. When we're asking ourselves the best practice, and you've just highlighted one reproductive health service. maybe we need to start with the question of, do we have the same problem when it comes to other reproductive health services? I think let's, for example, look at HIV and AIDS. Kenya is among the countries that have made significant progress in dealing with HIV and AIDS as a reproductive health issue. What measures did we take to tackle the stigma, to tackle the regression, to tackle the moral, religious connotations that hindered access to care? And for us as lawyers, we may want to look at the legal and policy framework. Let us look at the law, let us look at the policy addressing HIV and AIDS. And then let us look at maternal health care, serving women who are expectant to delivery and to post-delivery care. You also realize that there is not so much contention. The challenge we are having with Dr. Were's group and team and the healthcare system is about the quality of care. It is no longer a conversation about who can access, when, and who can provide. We are basically saying now improve the quality of care. But when it comes to certain reproductive health care services, access to safe abortion is one of them, the other is contraception, we then begin to have, we now stop applying human rights standards or laws, as Godfrey said, but we now all of a sudden change. We want to apply religious standards, we want to apply moral standards. So what do we see as best practices? I summarize the best practices as being captured in the human rights standards, internationally, regionally, and nationally, that then promote access to reproductive health care, in particular, referring to your question, when we talk about stigmatized care like access to safe abortion, stigmatized care like young people, adolescents accessing contraception. And continentally, I want to, and of course Kenya, our Article 2.6 of the Constitution. Let us look continentally. What does the Maputo Protocol say? The protocol to the African Charter on the rights of women. One, it then provides the framework for access not just to health, but reproductive health care. And therein, including access to safe abortion and contraception, the Maputo Protocol provides the framework. But that is looking within the continent. Globally, the Universal Declaration of Human Rights sets the basic standards. Convention on Elimination of All Discrimination Against Women sets the standards. The International Convention on Economic, Social, and Cultural Rights, they set the standards. And for us as jurists, we need to ask ourselves, what have the treaty monitoring bodies told us of the synthesized particulars of those standards? What should we do as countries? What should we do as legal practitioners? What should we do as policy makers? What should we do as lawmakers? Because those are then the standards that need to get into our laws, and where we realize that there is a gap, we need to fill that up in legal reform, policy reform, or litigation, so that we have progressive decisions. But to be more particular, beyond the broad legal standards, then we need to look at the best practice, the question of comprehensive sex education. I mean, we started talking about the right to information here. How does it look like? Information on health. That information, when it pertains to sexual reproductive health for young people. As a country, as a continent, Kenya, we are talking about the triple threat. Why do we have teen pregnancies? Because we do not discuss the question of sex in time. One, what are the challenges? How do you protect yourself from pregnancies? How do you enjoy safe sex if you are to have sex? And what are the consequences, for example, of early pregnancies? What are the health risks that comes with it? How do you prevent it? But then that also relates to HIV prevention, gender-based violence. Our statistics are big on teen pregnancies, but we also particularize who makes most of our children pregnant. Some of the pregnancies arise out of their consensual relations, but a lot of it is out of exploitation. It's out of coercion. What happens to the victims? In 2006, for Kenya, we became very progressive, and in passing the sexual offenses law, we made provision to redress the needs of survivors of sexual violence in law, not just the criminal justice process of holding perpetrators accountable. We set a framework for medical remedy. Do we respect it? The answer is no. Why? Because we then start to apply different standards. And that brings me back to what you said about our litigation. And I want to tie the morning conversation and the conversation we are having now. In the year 2012, immediately after the promulgation of the new constitution, the Ministry of Health developed standards for service providers to provide safe abortion within our Article 26(4). They applied them in training and providing care for 1 year. They were unilaterally withdrawn and training was banned. Civil society organizations went to court, and I can see in this room part of council that were in court. Tina Lai was there, Dimas was there under Article 19. Tina by then was with Physicians for Human Rights. And these actions were challenged. And ultimately in 2019, a bench of 5 judges, and it is worth mentioning because as jurists, we need to recognize when our colleagues make the bold move. Because when we talk about accountability, we single out individuals. And that was Justice Muchelule, Justice Achode, Justice Mativo, Justice Odunga, Justice Achode, and Mumbi Ngugi. I hope I've mentioned all the 5. Sitting in that case, one interpreted the application of Article 26(4) of our Constitution in the context of fundamental rights and freedom, the Bill of Rights, that the issue abortion is a fundamental right in Kenya, limited as provided in Article 26(4), and pronounced itself on so many other things that we need to reiterate. One, that if you have a right provided for in the Constitution, you cannot have the blanket prohibition sitting in the penal code. Two, that while Kenya politically made a reservation to that regional instrument, Maputo Protocol, we have constitutionalized the question of access to abortion. We passed a law that was way before 2010, the Sexual Offences Act, that provided for survivors of sexual violence, those rape, defilement, incest, should they so choose, they are allowed to terminate the pregnancy. And therefore, the government cannot, the political reservation to the Maputo Protocol is inoperative. Why? Because we have set for ourselves a higher constitutional threshold and statutory threshold. And so you realize that then that is what the courts gave us back. And of course, the court reinstated the guidelines, reinstated training, quashed the banning of training and the threats to healthcare providers. But quickly down the line, as Dr. Were was enumerating, a service provider is arrested somewhere in Kilifi because he provided emergency care and is arrested together with the patient. And the first place they are taken is a public health hospital where mandatory medical examination for purposes of extracting information to charge this survivor with abortion is done. And they are dragged to court and charged, both provider and patient. And because we are jurists here, it is worth noting that when the trial court, the magistrate court, could not hear the plea of the accused that the charges against us are by themselves unconstitutional because we were performing a constitutional responsibility. We are acting within what we are trained to do in law and what is lawful, and the patient is a survivor of sexual violence allowed to access remedy in law that you cannot try us. The court said, no, I will hear you in your defense. The matter moves to the High Court.
Just put it in a nutshell. It restricts abortion or legal termination of pregnancy only to those circumstances where the pregnancy poses a risk to the pregnant girl or woman. So actually, as I'm speaking now, I am quite anxious because we have just filed a case, which I'm going to share with you, and we are serving now on the Attorney General, the Minister of Health, and even the Malawi Human Rights Commission. So I have been in the advocacy for law reform on abortion for a long time, since 2008. And our aim was to get the law to be reformed, to be overhauled. Right? But in 2021, we hit a snag, because when we took the termination of pregnancy bill that the Law Commission of Malawi had proposed to government on how the law can be reformed, the parliament refused even to look at it. Okay, so we were thinking, what do we do now? But of course, we are continuing to change the law, to reform the law, but we also realized something, that even under the current law, some eligible candidates are not able to access self-termination of pregnancy, including young girls who have been raped and have become pregnant as a result of that sexual violation, are not able to access self-termination of pregnancy. So we thought, okay, we are aiming for a complete overhaul. But here we have got a situation where this is legally permissible, but the person is not able to access this termination. Why is it so? Because the health providers are interpreting it in various ways. Others are saying, yes, you can provide termination of pregnancy to a girl who has been raped. Others are saying, no, our hands are tied by the law. So we thought this is a good area to do litigation, to clarify the law as it applies to a certain group of people, and in this case, a girl who has been raped. So this case is about a 13-year-old girl who was raped, and when she went to a health clinic to assess legal termination of pregnancy, she was just turned back. Then we thought, okay, this is an instance where now we can get the court to clarify the law. So this is the case we have filed after preparing for a number of months, that we should clarify access to self-termination for pregnancy. But this is quite critical. It will not only clarify what the law is, but one of the challenges with the, as Dr. Andrew you're talking about, is even the information. There is no accurate information about eligibility to access self-termination of pregnancy, even if it is there, you know. There's no, so people actually, some people who need self-termination of pregnancy, and it is legal, you find that they go to quacks, because they do not know that they are eligible for legal termination of pregnancy. So we hope that that is what, even if we are not going to reform the law using this litigation, but perhaps it will clarify certain issues that will also assist in us providing accurate information to eligible candidates, that for your case, you know, this is you can access self-termination of pregnancy, and even the doctors must provide confidently, knowing that this is clarified by an authority, that this is legal. So, but we are still anxious, because, I mean, when we go to court, we don't know what will happen. What I hope for is that the court will go to a full determination of the case. Because if it does that, I have the confidence that, I mean, our courts have been dealing with the question of whether, what is the meaning of majority in presidential election. It clarified that. Can it fail to clarify whether this girl can access legal termination of pregnancy? I don't think so. Unless maybe there are other factors that, you know, prevent the court from getting a full determination. So, yeah, I think that's what we are doing so far. And we hope that, because some of my colleagues were asking, well, will it eventually, you know, how does this contribute to reforming the law? And I say sometimes when we have a good judgment, the court can even plant the seeds for reform in its judgment. Because at the end of the day, we want a law that is really clear. And it could ask Parliament to say, hey, can you look at the fuzzy area here? Maybe this is your role now to create a better legal instrument than one that requires constant interpretation and reinterpretation. So maybe let me stop there.
You'll find in the penal codes is that they are all drawn from the 1861 Offences Against the Persons Act of the United Kingdom, which over the years has been repealed. So 1861 to 2023, how many years are those? Yeah, like 200 years, right? And, you know, the UK has since repealed those laws, but us, you know, the former colonies of the United Kingdom still retain those laws, you know, despite what the public health, data is saying. And that brings me to my next question to Dr. Were. Abortion is a public health issue. It is a medical issue. Personally, I believe it should not be a legal issue because it affects, women's agency and autonomy. But again, it's, it's an issue that we are dealing with as a legal issue. But from a provider's perspective, how does a restrictive legal and policy framework affect women and girls' access to reproductive health care? And like we have heard from numerous sources about the number of surgeries that have to be undertaken to repair uteruses at the Kenyatta Hospital.
Yeah, thank you, Prudence. Restrictive environment, as I mentioned before. One pushes these girls and the young women to go to backstreet access of services, reproductive health services. And I think I need to paint a picture because there's a certain healthcare practitioner who, an obstetrician, who had refused to provide care to a young girl. This young girl then went into the streets, then got messed up. He ended up going into kidney failure, was admitted in ICU, and died like a week later. Then this doctor, when he was passing by the village, he saw a hearse passing over, then asked who was that was going to be buried. And he was told that was a certain girl, and remember that this is the same girl that she actually refused to provide service. And that really touched that particular doctor to a point that he became now an advocate of access to reproductive health service. And it's something that happens almost on a daily basis, where we're using young women who can actually be very productive and change this country because of these policies that have been pushed, and as I mentioned, not from a scientific angle, but from a religious and moral angle. And I believe as a country we are a secular state. And in the morning when we're having the discussion, I was wondering who holds the judiciary accountable. LSK can complain about what is happening in GSC, but what more can be done? And I think it's a challenge to the lawyers and the judges. It's for us to change and to stop these young women actually from dying. We really have to just do the right thing. I think the previous president for LSK used to talk about professionalism and how it's been attacked, both even us in the medical field. That was the same thing where we are having that Christian health society, where we're having individuals who are actually misinforming the public. So we need to actually come up and address through litigation and change these restrictive policies that are actually preventing doctors from providing what they were trained to do, from doing the right thing as provided by the Constitution. So it drives them to the back street. Once they go there, they harm, because just try put that numbers that you have had 3,000 funerals of young women by December 31st. What impact it has on the society. And most of the time, we normally assume that these may be first-time mothers. They're not. We have married women who are assessing abortion, who also have to go to the back street. Maybe they have a cover that covers them in Nairobi hospital. They can't do that because they are afraid of what the healthcare workers will think about them. They're afraid of maybe being caught up, or maybe the husband knowing. Well, you may find that there's actually a legal backing, as Dr. Kangaude said, to get that. The other issue is then once they miss that opportunity and they go to the backseat, if they survive, then they're also denied the information to correct that particular issue. They do not have access to reproductive health information. They do not have access to contraceptives. Actually, just go through the penal code, and actually even to prescribe, self-prescribe a contraceptive, which is, if you interpret it to stop conception, it's illegal. So the impact that it has on the society is very big, and that's why we cannot really develop and change if we do not get to the bottom of this and address the issues that is facing the young women and girls.
You know, in my honest opinion, there's an irony to it all. Like when you read the papers, particularly here in Kenya, women and girls are dying each day from, you know, gender-related killings, you know, femicide, you know, intimate partner violence, and yet femicide is not recognized as a criminal offense under the Kenyan laws. And again, when you look at it, women are dying daily, you know, because of unsafe abortions, and yet, you know, the government is pushing back on, you know, liberalizing the abortion and the legal and policy framework when it comes to access to safe and legal abortion. And that takes me to my next and final question to you, Martin. From the Center for Reproductive Rights perspective, what more, you know, can jurists do? What can civil society do, the academia, you know, the medical practitioners, you know, to ensure that women and girls can access SRHR in this country?
Thanks, Prudence. So huge. I will just try to unpack a few things that I can say. What can we do, especially with the tools that are available to jurists? I think we need to, first of all, just understand when we look at socioeconomic rights and come down to health as a right, we then need to ask ourselves, where are the challenges coming from and who is disproportionately affected? If we understand that, then how we relate, how we intervene can be more effective. That we are looking at the indigent in our communities most affected. We are looking at women and girls most affected. And when we are looking at the girls, we are looking at the adolescent. And we know the power dynamics in the society. So we are looking at the poor, we are looking at the young, the ones who are affected mostly. And when the conversation here is honed around, there's a lot of conversation around access to safe abortion and contraception. Actually, other reproductive healthcare services are also struggling. Just access to information on anything health, you still have taps closed there. When I said here, when we talk about cancer treatment, for example, we are now just catching up that cancer is a national pandemic. But how did we get there? When did we stop paying attention? So what can we do as jurists to move from that big conversation? One, let us look at health comprehensively. Health is not just malaria and diarrhea, but let us focus on what affects all of us and what affects most of us. Sexual reproductive healthcare services are at the core of healthcare services that affect most of us. And then legal advocacy. I think we can diagnose the problem. The health professionals can tell us what the problem is. Part of the solution lies in law, policy, and administrative reform. So we cannot run away from legal advocacy, in my view. Let's be in courts, let's do memorandum, let's be in parliament, let's go before the national human rights institutions across the continent. Let us go before the Africa Human Rights Mechanism. We cannot stop legal advocacy and litigation. But of course, legal education and awareness is key. If we know, then we can intervene. If, for example, all of us in the room today acknowledge that obstetric violence is a violation of human rights, that any woman seeking a delivery service should be treated with dignity, with compassion, and get the quality of care they deserve, then that knowledge alone will, when you see it, you can intervene. If you don't know, then you can't intervene, and you may join the trail of normalizing violations instead of calling them out when they happen. Of course, capacity building for those of us who sit in the bench, for those of us who sit in the prosecution, for those of us who practice, those of us who are researchers. Let us build our own capacities in understanding not just health as a right broadly, but let's hone it down a bit to focus on sexual reproductive health and rights, where we find a broad range of issues that affect a very big population. Of course, public awareness cuts across the board, in my view. And of course, for us, then collaboration and combination of efforts, so that what you do as jurists should then complement what healthcare providers do, what law enforcement officers do, what children protection officers do, and so on and so forth. Thank you.
Thanks, Martin. I know I stand up. And my last question to Dr. Were and Dr. Kangaude. What are the respective initiatives that your organizations are undertaking to ensure that women and girls have increased access to SRHR?
Thank you, Prudence. I think we all need to be aware that in 3 days' time we are launching the Universal Health Cover, which emphasizes on preventive and promotive health. And one of the things that we're talking about SRHR that is going to feature very prominently in that is actually preventive is providing that information. So we need to look at it and find how we're going then to provide the sexual and reproductive health information to these adolescents and young women to be able to use. Preventive, what do we do? Preventive is about the contraception. How can they have this contraception access? How can we review policy and legal framework to ensure that these young women are able actually to access the right to health services. So those are some of the things that we need to look at as we look forward to launch the UHC, and I think that's a very big opportunity for us. But what we are doing as a Medical Student Association of Kenya, working with the Law Student Association of Kenya, we are actually trying to now, we are training the medical students and the law students to be able to actually generate one evidence that can actually be used as a basis of the litigation, so that we have the data and we're able to actually have them conduct the research together and paint the real picture of the ground, because I think that is normally lost on us when you go litigate on these issues. We're also training them on value clarification. So we're going to produce a youth movement based of medical practitioners and legal practitioners, including nurses, lab techs, and clinicians, so that they can be able to provide these services for the youth. Because one also of the barrier to access to these services is actually us as healthcare practitioners. We are, our generation is very judgmental. When a young woman comes, you start asking very uncomfortable question. Why did you engage in sex? Why you didn't think about your future? Why are you coming here pregnant? And why do you want to have contraceptive access? So we're also trying to have a community of the youth, because one of the things that is lacking in the reproductive health policy that was even passed last year was the youth voice. So we are trying to train this team of medical legal students and the alumni network when they go into practice to be able to analyze these laws, to be able to come up with memoranda that they can be able to submit to the policymakers, and to actually challenge the policymakers when they make these laws without their input. Who are they making for? Because I've seen in the program the AG is the one who's going to close. And in the AG last year, in one of the rulings about the stakeholder involvement, mentioned that the stakeholder involvement is just not an exercise, it's not a cosmetic exercise. You must actually demonstrate that you actually incorporated, or if you did not incorporate the views from the stakeholders, who are these adolescents and the young women and the youth, then why did you leave it out? And I think that is one area that also we need to look at, because when we capacity build them to be able to handle and present memorandums, then we should also be able to track that actually their views and their way of thinking and their needs are actually catered in the laws. So that's, in essence, is what Msake is doing, building that youth movement that is well informed, and that when it comes to the provision of the services, whether medical and legal, then they are all aligned in terms of meeting the goals that we need to. Thank you.
Yeah, so in addition to what one of the biggest challenges actually is how do we deal with the deep-rooted anxieties and fears in the society about these specific issues. You know, the fear that somehow if we do provide comprehensive sexuality education, if we do respect the sexual rights of the child, then something terrible will happen to society and it will collapse somewhat. How do we convince society that it is actually better that girls and women access legal termination of pregnancy, and society is not going to collapse because of that? It's actually going to be better, but these are the deep challenges. We can litigate, we can talk about the mechanics of the law, but if the public are over there and we are in court, then we still have a problem. We need the public to support us, that to understand that when we provide comprehensive sexuality education, things are actually going to be better. We need to, how do we convince society to do that? No? Maybe we need research that can convince people to see that we can actually do this and things will be better. Because that's the fear in the society, that no, if we are going to relax, if we are going to talk about decriminalization of consensual sex amongst adolescents, then something terrible will happen to us. We need to keep these laws. That's why we are struggling. No, we need to keep these laws restricting termination of pregnancy, because as soon as we relax them, all the women will be rushing to be terminating pregnancies anyhow. How do we address that? So maybe we need to do research. Maybe we need to do social legal research that will help us even convince the judges to who we are appearing. Because we can use the mechanics of the law. Yes, this law says that, an application did, but can we tell stories that can convince the judges to say, yes, I think we can confidently decide in this manner because what you're saying makes a lot of sense. For me, that's a big challenge. So one of the things we want to do, for instance, when we are supporting this girl to do litigation, is actually to go to the grassroots and to explain why we are litigating, so that when they hear it in the media, or in the media, they can connect to what's going on in their communities. Because if we litigate and the people's power is elsewhere, then that is sort of deficient public interest litigation. We need the people with us. It's a big challenge, but we just have to do that. Thank you so much.